in relation to the two reports that were published last week, both the 2015-2017 corporate report and also the findings of the employee survey. And I read them both in one sitting. And you admitted yesterday that the findings in the survey report was tough reading for someone as a head of the health service. And I guess when I read the two of them, I was really struck by the gap between the intent and the aspiration in the corporate report and the very stark findings in employees' experience. And I'm interested in what struck you most about the survey, employee survey.
Well, of course, there needs to be a gap, because the plan is about what we'd like things to be like in 3 years' time, whereas the survey is reflecting how things are and how they've been over a period of time. So while it was tough reading, it wasn't particularly surprising reading. When Michael West was here on this platform last year, and he gave us an insight into the 12 years of work in the NHS, very clear, first of all, that we needed to do the survey. We needed to find out what the baseline was, and we needed to make sure that by doing so, we were going to be open and honest enough to honestly reflect back to everyone who took part what the results of the survey were. And that's simply because that old maxim that I used yesterday, that good strategy begins with brutal honesty, is absolutely true. Unless we know what the problem is, we can't begin to strategize how to fix it.
Yeah, and I think you deserve credit for doing it and publishing it. But what struck you most? One thing that really struck you about the findings?
I wouldn't say there was one thing. There were positive and negatives. And that's not just kind of a spin thing. The level of commitment that people have to their own jobs is the greatest strength that we have. The difficulty, I think, is the extent to which the people who provide our services have become alienated from us, by which I mean kind of all of us, partly through our own actions and partly through the things that have been foisted upon us. So the way in which the health service relates to its staff is a function of a lot of centrally directed policies that the HSE, the hospitals, the community organisations and some of the voluntary bodies are but a cipher for. And to some extent, we as managers have become synonymous with policies that we didn't agree with, didn't want, and now wish to change. And as well as changing those policies, we need to rebuild that relationship in order to regain the trust, I think, of the people who work in the service, and to give some hope that things will get better, which I believe they will.
Okay. The first value specified in the corporate report is care. And yet, in the survey, 1/3 of respondents either disagreed or strongly disagreed, and I quote, that care of patients is the health service top priority. Given that the fundamental role of a health service is care, and that's in very sharp contrast to the priorities in the corporate report, do you not think that's an extremely worrying finding?
It is worrying, but I think it's, in some ways, it's a reflection of your own research that yourself and Sara presented here last year, in that when you asked people to track how their time was, as managers, as leaders, how their time was being spent, they were able to differentiate between how they would wish to spend their time and how government priorities suggested we should spend our time, and how the day-to-day reality was forcing them to spend time. So whether they're in the community sector having to deal with, frankly, farcical attempts to reduce the cost of medical cards through so-called probity exercises, or the implementation of some of the more meaningless Haddington Road targets, these things become very preoccupying for managers. And it's often the case that we become collectively, and I refer to me and ourselves here, often become really concerned about the things that we can't do, but are being driven to do by others, sometimes at the exclusion of addressing the things that we can do. And so the fact that our staff perceive that care is not the top of our agenda is probably just a reflection of that, and we need to change that.
Okay. Care is the bread and butter of any health service, and central to this is quality services and safe services. There's been a lot of bad news about maternity services in Ireland, most recently concerns over Portlaoise. If this convention centre was filled with pregnant women of County Laois, or pregnant women, I'm sure there's a good few pregnant women in the audience, what can you do to reassure them about the safety of maternity services now?
Well, when HICWA publish their report, as eventually they will in the not too distant future, one of the lines that's in the draft report suggests that the services in Portlaoise are in fact safe. They're not questioning the current safety of those services. So in all the noise that goes on in the background, and it's part of the dilemma, I guess, we have, when we're having necessary investigations when things have gone wrong, there tends to be in that fog and that mist a distraction from the current realities. And it's important to stress that while there are things that can be improved and must be improved, and while there were definitely things that did go wrong in Portlaoise and in some other places, there is no finding that the services in Portlaoise are currently unsafe. It's very important that that is reflected accurately and as prominently as everything else in any report that's published.
And yet, Tony, it is a very public and dirty spat that's going on at the moment between the HSE and HICWA. And we know from previous inquiries, from the work of Tony Holohan and others, that the HSE has a poor track record of acting upon recommendations. Just to name one, the HICWA report into the death of Savita Halappanavar stated very clearly that if we'd learned from the death of Tanya McCabe, some of these mistakes hadn't been made. So how on earth can I or anyone believe that lessons are being learned, that services are improving, that the services are safe? There's a credibility gap between what you say and what we read in these reports.
Well, first of all, there is a fundamental truth that at times there has been a problem with translating nationally things that have been learned locally. And the particular case you mentioned is a good example of that. And many of the processes that were developed before my time were designed specifically to address that and have done so to a large extent. The key thing here, and you refer to this spat, first of all, the HSE didn't put this spat into the public domain. Other people did that for their own reasons, and I think they'll probably come to regret having done so. The issue here is that regulation must be of sufficiently high quality that it can gain the confidence and support of the whole of society, including those who are being regulated. And I'm sure that that's what will happen ultimately. But learning is not supported or fostered by knee-jerk blame reactions, either from managers, from the media, or from regulators. And that's something that we all have to accept. And I think the recent Morecambe Bay investigation, which was a parliamentary level investigation, demonstrates that regulation is so important to the quality of healthcare that it must be done in the right way. And that's really the only point that I and the HSE have been making in relation to what you've called the spat.
Okay. Ours Attractor was another real low in terms of the abuse of people in the care of the HSE. And after that, you issued, I think what was quite an unusual email to staff, really telling staff that their core business was care and that they should treat the people they're looking after as if they were family members. Yet a year on from the expose of the RS Attractor, the HIC report found some improvements in that home, but it also had some very real concerns for the well-being and safety of residents. And I know you've done other things like putting the confidential confidant in place. But why is that? Why is it that the HSE doesn't seem to learn from the lessons of the past?
Well, when you said a year on, I think you're probably referring to Portlaoise. Oris Attractor is a few months ago, about 4 months. And the recent HICWA investigation took place, I think, in the very beginning of January. It was only published in April. And I was very struck by the comments made by Inclusion Ireland, who are strong advocates for people with intellectual disabilities, who recognise that the type of culture change that is required to overcome the behaviours that we saw, which were and are completely unacceptable and are, of course, the subject of criminal investigation, that can't be changed in 4 or 5 weeks. The other key lesson is that the kind of tick box approach to regulatory improvement, which, and I say this not in a critical way about the regulator or anybody else, putting in place training plans, having sheets that can confirm that various people have had training. If Oris Attractor tells us anything, it tells us that that's not enough. I think it also tells us that very speedy inspections after controversies are unlikely to have found significant change. Now, obviously, the individual staff were no longer on duty. Lots of other staff from other locations are there caring for the residents, and clearly there is room for improvement. But fundamentally, those types of congregated settings cannot be part of the future. And Pat Healy, who leads our social care division, has been working very hard to quantify what's required to make that quantum shift. These don't look like high-walled institutions, but they're only one step away from them. Many of the residents came from those institutions, Some of the staff came from those institutions. And what goes on behind a closed door in any institution, in the absence of a camera in a rucksack hanging on a clothes hook, is unfortunately something that's very difficult to control.
And yet the HSE has been extremely slow to move on moving people out of those congregated settings. Just a couple of hundred people have been moved out since the report was published.
The HSE has been moving at the pace at which resources have been provided to it.
Okay. One of the highest profile health stories over the last few years has been people losing their medical cards, in particular the discretionary medical cards. When people walked out of the polling booths after the European and local elections last year, they told posters the main reason for anger with the government was the loss of medical cards. And actually, if you go back to your own service plan for 2013, you detailed how 40,000 people would lose their discretionary medical cards for various reasons. What caused that medical card debacle, and what could have prevented it?
Two things caused it. One is that the government, which sets policy and decides the thresholds, the financial thresholds, moved those thresholds downwards. The net effect of that was that people who would otherwise or previously have qualified for medical cards no longer did. And that was foreseeable. It was written in the service plans. It was a tacit policy decision to do that. The second, and I've referred to it earlier, was this crazy stuff about medical card probity. It was sprung on the health side negotiating team, and I was in the room when it was sprung.
Who sprung it?
The Department for Public Expenditure and Reform. Now, clearly they have a difficult job to do. They had to make numbers that didn't add up. And as these budget negotiations come to their conclusion, sometimes things are seized upon. And I think they seized upon an old report that had in fact been commissioned by the HSE a number of years ago that suggested that various process changes could improve the extent to which only those who are eligible could have medical cards. He ignored everything that had been done in the meantime and came up with this mad number, which they originally called medical card fraud. Now, we persuaded them, and perhaps it would have been a better thing not to persuade them, that they couldn't use that term. Those in health, which isn't just HSE, but the Department of Health, made very clear that this spelt disaster. We knew the election was coming. We indicated very clearly what the consequences would be. But, we can only do so much. And the consequences of that decision were inevitable. The great regret is the degree of fear and alarm that was experienced in the country as a result of that, and the backlash the ordinary HSE staff in the primary care reimbursement service experienced for a decision that they didn't make. So it was an inevitable disaster. And at the time, as you recall, just as I will take issue with HICWA where I need to, in the government press centre, on the day of the budget, I made it absolutely clear that the HSE had no hand act or part in that decision and didn't think it would work.
Do you think prescription charges for medical card holders should be abolished? Yes or no? Yes or no?
I have to qualify. Personal view, yes.
Do you think hospital groups will become independent hospital trusts?
I think they'll...
Yes or no? Come on, this is meant to be quick.
Not for 3 years, and we need to be clear what it means, because nobody yet knows that.
You're breaking all the rules.
Yeah.
By when will we have activity-based funding for all hospital treatment?
Probably never.
By when will we have electronic patient records for all patients across the health system?
National Children's Hospital when it opens, and thereafter it'll be spread out.
A year by when we will have electronic patient records for all patients? Ballpark?
Probably by the mid-2020s.
By when will the HSE have one integrated finance system? A year?
2018.
Will the target that no patient will wait more than 15 months for an outpatient, inpatient or day case appointment by year end be achieved?
With very few exceptions in certain specialties, yes.
Do you think it's okay to charge a patient retrospectively for their long-term care in the form of the nursing home support scheme when there is no charge for patients for anything else, such as cancer? Yes or no?
Personal view, no.
Do you think the nursing home support scheme, as it's currently structured and financed, is sustainable?
No. Will
the HSE exist in 2018?
Probably.
Will you still be HSE DG in 2018? Yes or no?
I don't know.
Okay.
I don't know whether I want to be either.
Yeah. Okay, we'll come back to that. Okay, let's shift the tempo a bit and bring us back to your origins, growing up in England as an Irish immigrant.
Well, I was a son of Irish immigrants rather than an Irish immigrant. I was born in England, and I sometimes make the point that I was born in an NHS hospital, but I've always regarded myself as Irish. And interestingly, my sister, who's a little older than me, always regarded herself as English. It's one of those strange artifacts of the Irish diaspora. And I've lived in Ireland now since 1991. So, although I still have the somewhat strange accent, in England now people think I have an Irish accent, which is really bizarre, because I don't think I do.
But most of your working life has been here?
Yeah, at this stage, yeah, the majority of it.
In different roles, starting off in the Irish Family Planning Association?
My first job here was as Chief Executive of the Irish Family Planning Association. I came just at the time when it was being fined £400 for selling a condom in the Virgin Megastore, which on appeal was increased to £500. And within 2 or 3 years of that, interestingly, the government under Brendan Howland was spending an enormous amount of money promoting the use of condoms. So the extent of social, sort of moral, ethical change in Ireland in the years that I've been living here has been extraordinary by comparison with any other country, I think.
You were anointed by James Reilly as HSE DG, which I always felt was a poison chalice. But you were appointed to an organisation that he said he would abolish, yet 4 years on, James Reilly's long gone, the HSE is not abolished, and you're nearly 3 years as either acting or DG. How have you found the role?
Interesting is the one-word answer. I mean, I didn't ask James Reilly for the job, but I didn't turn it down either, because it's the type of job you don't really turn down. I'm not sure that I was anointed as such, because you know, the prospect of having holy water poured over me by James Reilly is a little bit too much to bear. But it's a very, let's be clear, it's one of those jobs that you simply wouldn't turn down. It has enormous opportunity, enormous variety.
What's your greatest achievement to date?
Oh, still being here.
Okay. And your greatest frustration?
Still being here.
Okay. I'm a pretty close watcher of the HSE and its structure, but even my head spins when I think about the amount of change or structural change the organisation has gone through since its formation, from the National Hospitals Office, PCCC, to regional offices and integrated services, and now hospital groups and community health organisations. Why is this new structure going to work?
What the new structure, it's kind of less about a structure than a mindset, is about creating the vehicles for the delivery of healthcare that will be sufficiently resilient to remain whatever happens to the HSE as a corporate entity. You know, in 12 months' time or so, we're going to have a general election. We don't know what the shape of that government's going to be. But if it's a different government, it's going to have its own ideas and its own plans. And the key thing for us is to have a health delivery system which is capable, without massive upheaval, of adapting to whatever those plans are. You know, abolishing the HSE in 2 or 3 years was never a viable proposition. Creating it quickly in road crash fashion was easy. We just took everything and crammed it together. But parceling that out, dealing with all the legislative implications, is very complex. So what we're trying to do is implement the hospital groups, which is taking longer than anyone would have thought. Now implementing the community health organisations, putting in national specialist services like the National Ambulance Service as a potential future trust as well, and redefining what the centre does. So it doesn't particularly matter whether you're in a UHI environment or a Fianna Fáil government or a Fine Gael government or whatever kind of government you care to imagine.
But you really think these structures are the right structures?
I do. I was never a fan of the creation of a single monolithic HSE. I was working in breast check at the time, did everything I could to keep breast check and subsequently the cancer screening service out of the HSE. Eventually lost that battle when Mary Harney amalgamated the NCS with the HSE. And, you know, it's a model of old-fashioned Stalinist structuralism. And while it's not easy to do, the aim here is to progressively ensure that we create these new delivery systems, the community health organisations, the hospital groups, etc., and genuinely empower them and only have the centre do what the centre should do. The HSE from its beginnings, and it was driven to do this was a policy direction, was doing things at the centre that should never be done at the centre, therefore becoming increasingly disempowering of everyone else. And you know, it became no more than a mudguard, really, for various failed policies.
Every year since you've been the Director General, the HSE has needed a supplementary budget. I totted it up yesterday. If you put together the last 3 years, it's 1.259 billion in supplementary budgets under your reign. Do you think this is bad financial management, or are you just not getting enough money to meet the demand of services?
Well, funny enough, I'll be having this conversation with John McGuinness and others on Thursday. And in relation to 2013, when you discount the things that were in the service plan that the government decided not to do, the HSE actually made a profit of 25 million. Profit, you know, in broad terms. In 2014, because of some of the Haddington Road stuff and the medical card probity, there was a degree of fantasy about the HSE budget. So I'm not of the view that it's the result of bad financial management. This year, however, I am of the view that if we don't do better than we're doing now, there will be significant questions about financial management in the system. But in the past, what's been called overspending has actually been a story of underfunding, and I think you yourself may have made that point with Mary Wilson once or twice.
What's your big strategic leadership idea?
My big strategic leadership idea? You're looking at them.
And your vision for the health service?
Well, that can't be a yes or no.
No, we're back onto the...
Okay.
You don't have to answer yes or no.
First of all, you know, I'm not into this legacy concept that a lot of people go on about. I think if you focus on legacy, you get nothing done. What would I like to see whenever my 5-year contract comes to an end, and assuming it's not renewed? I would like by that point that we have significantly strengthened the pride and confidence both within the health service and from the population to the health service. And that's one of the reasons why I'm so focused on both the hospital groups and the community health organisations, because I think when we bring things closer to populations that people can relate to, we saw some of this yesterday in some of the presentations, that creates better relationships, that creates a more dynamic environment for decision making, and that will bring people more confidence. But it's also important that we genuinely change some of the things we're doing, and that we're open to some of the ideas that we've heard today. There's been a lot of talk about public sector reform these last few years. Most of it doesn't amount to a hill of beans. You know, there hasn't been any real reform. There have been cuts, there have been pay cuts, but we haven't fundamentally changed things. And at the HSE broad level, you probably can't do that. When you empower people at a meaningful level and create opportunities for experimentation and taking appropriate risk, I think we can do transformational change that way. So I want to create that environment.
You've described yourself as the unlikely Director General in various forums, and I think live on air the week you were anointed by James Reilly, I wrongly said it was a classic case of Peter Principle. And I think you have proved me wrong on pretty much every occasion I've listened to you or heard you speak then, and I think you do an extremely difficult job with which you get very little credit for. But you say you don't like legacies, but if I'm writing the history of the health system in 10, 20 years' time, how do you think I'll portray your legacy?
Well, hopefully not as a Peter Principle one. I hope that it will be possible to say that the health service in its broadest context is better when I leave it than it was when I joined this role. And I hope that by the end of my time I will have been able to stick to what I hope I've done so far, which is to do the job with a degree of honesty and integrity. I like to do things my own way, which isn't like a bombastic thing, but I have to be very conscious that, legally speaking, I'm the person who's accountable for an awful lot of things, and I need to do what I believe to be right. And I don't seek popularity. I don't seek to be unpopular either. But if you thought you could do this job for a day, a week, or a year and become somehow popular, you'd be completely misguided. So all I can do is be true to myself, and I hope live out the values that are actually expressed in the corporate plan. You know, honesty, compassion, learning, and so on. And I hope that I deal with everyone that I come into contact with fairly and openly, and don't do people harm unnecessarily. At the same time, sometimes you do have to make tough calls, and I hope I do that with respect and decency as well. Okay. If you can say that about me, I'll be reasonably happy if I'm still alive in 20 years.
Tony O'Brien, thank you very much.